Orthopaedic Oncology from Gujarat Cancer and Research Institute, Ahmedabad. He is specialist in benign and malignant bone and soft tissue tumors, metastatic spine tumors, and pathological fracture, limb salvage and complex reconstruction surgery, percutaneous injection therapy, and core needle biopsy. He having some intense clinical training. He has taken some intense clinical training at Tata Memorial Cancer Hospital, Mumbai. He worked as assistant professor for 3 years at Smear Hospital, Surat. And he having more than 10 years in the field of orthopedics. So it's our pleasure to have you here today, Dr. Rahul Parmar. And let's bring the session open.
Hello.
Yes, Rahul, we can hear you. You're audible.
Good morning, everyone. And thank you for inviting me here for the talk. Right. So can you share the presentation?
Yes, sir. Give me a minute.
Yeah. So today we'll be talking on one thing, that what is the need of the hour, or that this thing, bone tumors, and how one should be able to diagnose it, and what are the management and treatment regarding common benign tumors that come in day-to-day in orthopedic practice. So we shall begin. Next. So this is the outline how we are going to have the discussion, like the need of the hour. So what is the need actually here? So day by day the number of tumors are increasing, and even in the cases of routine orthopedic surgeons, they do get a lot of tumor cases and bony lytic lesions, and sometimes even they don't know what to do with the thing. And so it is utmost important to have thorough knowledge regarding how one should diagnose it, and not to do the things that may have the catastrophic outcome for the patient. Then we'll deal with the evaluation of patients in the term of, if a patient present with a musculoskeletal lesion, a bony lytic lesion, so how one should be able to evaluate the patient. And then we'll deal with some of the common benign tumors, the etiological aspect and management aspect. Next. So we'll begin with a case. This is a 35-year-old gentleman with, on the left you can see a lytic area with a sclerotic rim in the proximal femur. On left X-ray, it has some sort of a periostal reaction, if you can see. The orthopedic surgeon thought that it is just and presented with him with a pathological fracture. So he thought that is just a normal the traumatic fracture, and he put a nail inside. Now, next. Subsequently, after 1.5 months or down the line, that lesion progresses to this much extent, and the final histopatho came out to be an osteosarcoma. So it is a primary malignant bone tumor, and someone had put an implant inside that is going to hamper the whole femur, and the outcome of the patient in terms of limb salvage is also poor, as well as the overall survival of the patient is also hampered, just because he didn't diagnose it in the first go. Right? Next. This is a case of a 55-year-old female with pain in left hip. She presented to an orthopedic surgeon with X-ray of lesion in the left hip. He did an MR showing lytic lesion in proximal femur that is going up to the lesser trochanter. Right now, patient had only pain, and she didn't had any fall, but the surgeon decided to do something for her. Next case. Next slide, please. So what he did, that he thought it to be a benign lesion and continued with curettage cement and a fixation called as DHS. 1 month down the line, patient presented with, next slide, presented with, and the histopathology report came to be a solitary bone metastasis from a breast cancer patient. And the surgeon didn't had the history, or I mean the patient had a history of this thing, but it was long back, but he didn't acquire about it, and that leading to the wrong intervention. So patient had to undergo a second surgery, and it was a solitary bone metastasis. So we thought that if we at all remove the tumor and block, we can save the patient of future surgery, as well as we can think of getting her cure also. So we did an en bloc excision and a customized tumor prosthesis. So these cases will just have a highlight about how important it is to diagnose a bone tumor, because a benign tumor has a different kind of a treatment, a malignant tumor is altogether a different treatment, and metastatic tumors are also on a different pathway. So we have to be very sure before taking any patient for the definitive surgery. Next slide, please. So this is just give you a highlight about how the percentage wise the primary bone tumors are rare, and if we consider with metastatic tumors like metastatic bony disease, what we call as, that is lytic lesion presenting in patients with over the age of 40 years, we think of metastatic tumor first and myeloma second, and third a very clear-cut evident chondrosarcoma maybe we can say we can see in 40 years as well. But the ratio is like 1:300. Next slide. So now we'll start with evaluation of patient with a musculoskeletal lesion. Like whenever patient comes to an our OPD with a musculoskeletal lesion, what we do? So what are the presenting symptoms here? First of all, patient will have pain, like pain will be having for 1 month, a duration or something like that. The pain initially begins as an intermittent, then the severity is also low. Patient takes over-the-counter medicines and patient is happy. Then patient progresses to constant pain. Sometimes there is night pain also. Then patient develops symptoms of soft tissue swelling. So this all thing without any history of any significant trauma or any fall. Then patients come to our OPD. Next. So what we do in the physical examination? We'll look for any soft tissue mass or swelling around like for example, patient is having a swelling in around knee joint. So we'll examine the extent of that swelling. Then we'll see the overlying skin changes, whether it is discoloration of the skin or prominent veins are there or not. Then skin is tenting or not, or free from the tumor, that is the thing. Then we'll see the distal neurological examination and any vascular deficiency present or not. And we'll definitely see the joint above and below the lesion. As well as in cases of patient who is more than 40 years of age, we should be thinking of a metastatic disease first. So we'll be looking for local lymph node examination as well as appropriate examination of other systems, like in females we will see breast and thyroid, and males we will think of a prostate and abdomen first. Now that is a rule of thumb that if the mass is greater than 5 centimeter in maximum dimension and it is deep to the deep fascia, we should be consider it to be malignant until proven otherwise. This is a rule of thumb. Sometimes what I have seen in my practice, that many of times lesion that is located like superficially, but it is also deep to the fascia only, and the size may be like 5-6 centimeters. Some of the surgeons would tend to directly operate on that patient, thinking that it is a benign kind of a lesion, and then it turned out to be malignant, and that will be a catastrophe for the patient. Next slide. Then comes that what is the second part of the investigation is imaging studies. So plain radiographs remains key. It can give us the idea about the lesion location, where is it located, whether metaphyseal, epiphyseal, diaphyseal. That also gives us an idea about the tumor histology and matrix, whether it is a chondroid matrix or an osteoid matrix. Then periosteal reaction, there are so many types of periosteal reaction that typical an osteosarcoma, we can say sunburst kind of an appearance. And in Ewing's, we have seen onion peel, that is a irregular continuous periosteal reaction around it. And we also look for the associated soft tissue mass, soft tissue shadow that we appreciate on the X-ray, as well as 24 to 30% times we get patients with pathological fracture. So based on this medical history, that is utmost important, as well as physical examination and plain radiographs, bone tumors diagnosed accurately in around 80% of cases. At least we'll have an idea that something is wrong about this patient. Next, please. Next slide. So, like, next investigation of choice is an MRI. So, like, I will just give an example, brief about one thing that, like, look an example of a lesion in distal femur, and what my colleagues, orthopedic surgeon, will advise a MRI of knee joint. So what they are going to miss, like in knee joint, you will have a lesion location up to like only distal third of the femur. If you can see appreciate the MRI image on your right, the white part is a normal marrow and the black one is the tumorous process. So tumor process is going upwards, way upwards. And if we do only MR up to the knee joint, that is going to miss the major chunk of the tumor. So how one should write an MRI, that is also very important. MRI with contrast, that is also one thing that majorly missing I have seen across. That contrast, people don't, they will write only plain MR knee. So MRI with contrast. Second thing is the whole length, that is knee, I mean like tumor is around knee joint. So that should include knee as well as the whole hip, because we need to see the skip lesion as well. And third thing, that the scale. The scale is also very important and it helps in planning the final surgical resection, as we tend to, in cases of malignant tumors, we need to remove a healthy bone and healthy soft tissue all around. So we need a margin, good amount of margin, 2-3 centimeter upwards and downwards as well. So as well as MRI will help in terms of intramedullary extension as well as extraosseous soft tissue extent of the bone tumors, and anatomical location and relation to the tumor to the neurovascular bundle. That is also helpful in cases of our surgery. And the components of solid, cystic component, hemorrhagic, necrotic areas will guide our biopsy tract. Next, please. CT scan is generally we will do an X-ray first, then an MRI. And CT scan is for specific reasons only. Like in osteoid and we are particularly sure that on X-ray only we are seeing that nidus is there. And we are confirmatory, for confirmation we'll do a CT scan. The nidus of osteosarcoma is very well appreciated on CT than any other imaging modalities. And so we'll do a CT for osteosarcoma and not a MRI. Then in cases of large pelvic tumors, we'll have to assess the bony destruction to plan the final surgery as well as the reconstruction options. And sometimes to guide the biopsy as well, we'll need CT guided biopsy. So CT scan is also required there. And in cases of osteosarcoma, chondrosarcoma, we'll do a chest CT scan for metastatic to see the lung mets in the cases, and whether it is metastatic or non-metastatic, both for preoperative staging as well as postoperative follow-up. Next slide, please. Now comes the once we diagnose a case that this is an osteosarcoma. To give an example, with is a patient of osteosarcoma in distal femur, and now what is the next step? So we have seen HRCT, that is CT scan of chest. Patient is non-metastatic, but the other way that lung as well as the bones. The two sides that most of the primary bone tumors will go. So we will have to look for the bones as well. So that is, we do a bone scan, and even in cases of like enchondromas and multiple exostosis, we need to see whether the other bones are involved or not. So bone scan is mandatory for the this thing. Second one is FDG PET CT scan. That is the latest modality for staging workup. So in cases of Ewing sarcoma, we'll directly do a FDG PET scan. So what is basically FDG PET scan is it is kind of it depend upon the fluorodeoxyglucose, and the cancer cell will take the they have the high hyper metabolism, so they will give the maximum uptake in the active status, active sites. So we'll come to know whether there is tumor is located to the primary site only, or it has spread to the other bones and other soft tissues and lung as well or not. So PET scan is also like a staging workup as well as for follow-up after the surgery. So that is all about the staging of the patient. Now come the most important step of our diagnosis. Next slide, please. So whenever a patient with lytic lesion, be it whatever the benign tumor, giant cell tumor or something like that, I may be 100% sure that this is a case of giant cell tumor, or like say example distal radius. But still, what is our principle? We need to have a two-staged procedure, like biopsy first and then the definitive surgery. That has to be understood very well, because I may be right in 99 cases, but one case that I may wrong, that will have a very bad outcome for the patient in terms of the overall survival as well as the local recurrence. So what are the biopsy principles that we follow? Biopsy must be preceded by imaging studies, and it must be done by the final treating surgeon. So what is the inference? The final treating surgeon is the who is going to operate that patient finally after the biopsy results are coming out. So if one feels that this is a malignant tumor, one should directly refer it to the an orthopedic oncologist at the center they have city available, or a higher center. Because if one do a biopsy wrongly, that have a very bad outcome for the patient. Second thing, we plan the site and tract beforehand, because we have a plan in our mind that what we are going to do, and according to that, we'll plan our incision and tract for the definitive surgery. So what are the real risks and problems of the incorrect biopsies? That can spread the tumor cells locally, and that may facilitate the local tumor recurrence, as well as the change of treatment. As I have mentioned, if someone do an open biopsy and contaminate the whole field, it is very difficult for even a highly trained orthopedic oncologist to save the limb for that patient, and patient may end up in amputation only. Next slide, please. So this is a just a pictorial description of our core needle biopsy set. This is a daycare procedure done under local anesthesia, and usually patient will be discharged the same day. Next slide, please. So routinely in centers across India and world, the needle biopsy is the gold standard. It is a small step incision and daycare and under local anesthesia. Open biopsy is a longitudinal incision along the line of the incision, but it is more reliable because the larger tissue is obtained, but it requires admission and general anesthesia. At some point of time when needle biopsy is turning out to be negative, or some very specific indication, that we tend to go for open biopsies. Like 100 biopsies I will do only 2 or 3 open biopsy, rest all of them will be a needle biopsy. And one most important thing, that fine needle cytology, aspiration cytology, that is usually general surgeons do this thing for their biopsy cases, but FNAC has no role in bone and soft tissue sarcoma. That is most importantly to be noted. Next slide, please. So we'll come to the next part of the topic, that is benign bone tumors. These are the common benign bone tumors like osteoid and we'll be discussing their management. Accordingly, this is the, I mean to say that I will be discussing only the recent advancement, like what we are doing now and what was done previously, to give a brief idea about the change and recent advances we have in this field. Next slide, please. So what is osteoid osteoma? So it is one of the commonest benign bony tumors. It is affecting males in their second and third decades. And radiographic findings will be like, as I already mentioned, that CT is the best investigation for this thing. We will see a radiolucent nidus surrounded by reactive sclerosis bone, and particularly in the long bones of lower extremity. And site will be like in proximal femur, in distal femur, and patient will have an excruciating pain because of this thing. Many of them will have experienced night pain, and sometimes it is over-the-counter medicines. Then we'll now discuss the next slide, please. Next, click, please. So previously, what was the treatment like in like 10 years back, 15 years back? Whenever there is a case of osteoid, surgeons tend to go for an open surgery. They will try to locate that nidus. Nidus is very small. We cannot even see by naked eye. Even with the help of our image guidance, we are not able to locate the nidus as well. And it was causing extra morbidity to the patient, as well as chances of recurrence was very high. So nowadays, what we are doing is, the gold standard is CT-guided radiofrequency ablation. On the right, you can see the radio frequency ablation machine. And these are left side, we can see an X-ray of a CT scan of distal femur osteoid osteoma. Right? Next slide, please. So this is a probe on the top of the biopsy needle is inside the lesion. You can appreciate on the right most slide, on a CT scan slide. The needle is inside the lesion. There is a probe over it, and how the mechanism works. So radio frequency is like 90 degrees Celsius for 6 minutes. And that will destroy the nidus, that will burn out the nidus. And patient will have an excellent pain relief after the procedure. This can be done under a daycare procedure as well. And we routinely do it under CT scan guidance. But the thing is, the cost of the procedure and the probe is costly. So many a times patient can't afford this. So there is an alternative, what I have already mentioned, that CT guided drilling. Instead of putting this probe, we'll locate the nidus under the CT scan, and then we'll over drill it with a drill. Next, please. Next slide. Then we come to the simple bone cyst. So what is a simple bone cyst? It is a solitary fluid-filled benign bone cyst, where usually unicameral, that is a single chamber, or it may be septated, multi-septated as well. And it is most of affecting the extremities near the epiphyseal area. Most common site is proximal humerus, and second one is the proximal femur. It is mostly seen in pediatric age group during the active growth spurts, and sometimes they present with pathological fracture, and sometimes they heal spontaneously after pathological fracture, as well as most of the time they heal with maturity. Next slide, please. So just like simple bone cyst, just like osteoid, simple bone cyst had a long history. Like previously, surgeons tend to open it, then curate it, and then put bone graft or something, filling material, everything like that. but that only increases the morbidity to the patient. Recently, we have the concept of only putting injection therapy, what we call as, and the term used is curopsy, that we'll take the biopsy and we'll do the breakage of the wall, and that is we call as decompression of the cyst wall, and that drains out the inflammatory fluid out of it. So simple bone cyst is like not a true cyst, and because of the systemic inflammatory markers inside it, the fluid will be drained out during the decompression of cyst wall, and then at the same time we'll inject corticosteroid injection, or the options will be demineralized bone matrix or bone marrow aspirate. And on the left topmost image, you can see that a lesion in calcaneus, cystic lesion, that is healed beautifully only with the one injection. And in cases of weight-bearing bone, like in proximal femur, we'll put an implant like a pediatric DHS or something like that, and we'll do the same procedure, but just for the sake of that prophylactic fixation will be done. Next slide, please. Then we'll have a discussion regarding aneurysmal bone cyst. So they are benign expansile osteolytic lesion containing multiple blood-filled spaces, and it is separated by connective tissue septas composed by fibroblasts, giant cells, and trabecular bone. It is also common in pediatric age group. It has metaphyseal location, and simple bone cyst is located epiphyseally. It is also located in flat poles as well, and it is also misnomer that lesions are neither aneurysmal nor truly cystic, and they lack the endothelial wall. The differential diagnosis to aneurysmal bone cyst, it is many times seen with some other benign condition, like we can have giant cell tumor along with an aneurysmal bone cyst component. We have a chondroblastoma along with aneurysmal bone cyst component. But the worrisome part is that a malignant tumor known as a kind of an osteosarcoma, type of osteosarcoma variety, that is known as telangiectatic osteosarcoma. Aneurysmal bone cyst and telangiectatic osteosarcoma have a similar radiological appearance. So that is why we are telling that the biopsy is the utmost important step for the diagnosis. That is the reason that if someone said that this is aneurysmal bone cyst and they open it and they remove and scrap it out and they put something filler, and the final report came telangiectatic osteosarcoma, that is not going to help the patient. So telangiectatic osteosarcoma needs to be ruled out. Next slide, please. So previously, the treatment for aneurysmal bone cyst was same as simple bone cyst. We do curettage, remove the tumor bone, fill out the cavity with cement or bone graft. Over the period of years, that paper I have quoted came from AIMS. Long back, they have studied 72 cases, and they told that the injection that I have showed here, polidocanol injection, that is 3% polidocanol, used in main cases of varicose vein, and it is a sclerosant agent. So how does sclerosant work? It directly damages the endothelial lining, triggers a coagulation cascade, and that causes thrombotic occlusion of the blood vessels. So on the rightmost image, we can see a very good image of lytic lesion in acetabulum area. Acetabulum is as such a difficult area to assess by surgical means. So what we did, we do CT guided aspiration of this blood, and we put a polidocanol injection, and after 2 injections, the lesion is healed completely with a good sclerosis, and size is also decreased. So patient is pain free. So this is how the sclerotherapy works. Next slide, please. So these are the advantages of sclerotherapy. It is a simple procedure. There is no risk of morbidity in terms of surgical risk, and no great scar. A day care surgery, patient can be discharged in a span of 2-3 hours after the procedure, and it is very effective in cases of like inaccessible to in terms of surgical means, or the morbidity of the surgery is more cases of pelvis and sacrum. This is the like boon for the patients, the sclerotherapy. And local control is also comparable to intralesional curettage and with better functional outcome. Next slide, please. So now we are coming to the last part of our lecture, and giant cell tumor. This is the commonest bone tumor that encountered by an orthopedic surgeon during their OPD and clinics. Giant cell tumor is usually they are benign, but what I will call is an intermediate tumor. Like it is in between benign and malignant. Like what in terms of that? That it is locally aggressive, and it has very high chance of local recurrence, up to 20 to 30% chance that patient may have recurrence at the local site. Plus 2 to 5% cases will have a malignant transformation, and they will transfer to the lungs. Now, previously we were doing simple curettage for the giant cell tumor, but it has a high recurrence rate. So now it has been replaced by extended curettage. Like, so what is extended curettage? I will discuss in the next slide. And in rare cases, when there is a huge tumor or when an extra osseous component is huge, or in cases of recurrences, we use this tumor megaprosthesis as well. Next slide, please. So what is an extended curettage? So on the left, you can see an Campanaki grade 2 giant cell tumor of distal femur. This is a biopsy proven case. On right one, I have opened it, the tumor surface, and remove the tumor bit by bit. Then we'll use a high speed burr to grind the paratumorous bone, and I will increase my margin of the intralesional surgery, expand the range of curettage, and using chemical agents as well. We usually use hydrogen peroxide as well as 5% phenol and absolute alcohol. And last, we'll fill it with bone cement, so that the bone cement is also made up of polymethyl methacrylate. It has a tendency and it causes exothermic reaction as well. So it also helps in killing the tumor cells. So this is how we do the extended curettage. So nowadays, after doing extended curettage, I would say that recurrence rate that was previously like 20 to 30% has come down to around 5%. Next slide, please. Like this is a case that we did a few years back. This is a patient had recurrence of tumor. Previously, he was operated by some surgeon with put bone grafting and some screws and do the simple curettage. And because the lesion was very big, it was soft tissue extension as well, and the joint was also damaged to a far extent. So we decided and put a tumor megaprosthesis for the same. So tumor megaprosthesis is reserved for a few select cases of giant cell tumors, like recurrence and pathological fracture and large extraosseous component, and when joint is intra-articular extension of the tumor is present, right? So this is how we deal giant cell tumor. Most of the time, we'll try to preserve the natural joint by doing extended curettage, cement, as SOS plating to supplement the cement. In rare occurrence, we do a prosthesis. Next slide, please. Now, what is the recent advance in terms of medical management for GCD? Sometimes we'll have a patient of giant cell tumor of sacrum or giant cell tumor of spine that is very huge and encroaching on spinal cord, and sometimes surgery is very difficult for this patient, and even if we do a surgery, that will be a half surgery, or the morbidity of the surgery will be very high. So in such cases, now we have two molecules that one is the bisphosphonate, and we are using zoledronic acid that targets the osteoclast like giant cells that induce apoptosis and that limits the tumor progression. One thing, zoledronate comes at a cheaper rate, so we are using it frequently. Now the next molecule has come across India, that is denosumab, that is rank ligand inhibitor, that patients with locally advanced and surgically unsalvageable giant cell tumors, like in cases of pelvis and sacrum, that we are not going to operate it all. So we'll give denosumab for longer period of time, and we'll try to decrease the tumor size, as well as we'll continue giving denosumab for the time period till the tumor ceases. Or in cases of when I think that curettage is difficult and I may think I'm trying to preserve the joint, then also cases I will give denosumab, and that will facilitate my curettage. So this is how we commonly deal with our common benign tumors in nowadays. Next slide, please. So this is a yellow ribbon that is a sarcoma awareness ribbon, as we know. So what in our cases we deal with malignant bone tumors of pediatric patient and old ages in metastatic bone tumors. So we try to give the hope, strength, and love to the patient so that they can fight their disease in a manner that helps them. Thank you.
Okay, I request participants, if they have any doubt, they can drop that question in a chat box, or they can ask directly. By the time, I would like to inform all the participants that Dr. Rahul Parmar is running a bone and joint cancer clinic at Swaminarayan Complex, Majura Gate, Surat. Rahul, I'll be sharing your clinic details.
Sure.
So in future, if they are coming across any case and if they need your expertise and knowledge with that, it will be easy for them to approach you, right?
Yeah, sure.
All right.
So.
Good morning,
so
sir.
Thank you, Dr. Rahul Parmar, for giving an insight on that, bone tumors and the malignancies, especially on the diagnostic approach. The examples that you shared with us was, very, I think it made us very easy to understand all those X-rays, MRIs, and the diagnostic approach with the management line. So it was a very informative session. Thank you so much on the behalf of Srimad Rajchandra College of Physiotherapy, Dr. Bhavik, for coordinating the whole session with us.
And we have one query. Maitri,
yes,
you can unmute yourself and ask a question.
Yes, I actually wanted to ask what are the exact causes of bone tumor?
Okay, so most of the time, like in terms of causes, that some of them are hereditary. Some of the benign bony tumors are hereditary, like hereditary multiple exostosis. What we commonly see, that bony outgrowth. I have not covered in this topic. That exostosis is one of the hereditary causes, as well as enchondroma. There are multiple enchondromatosis, what we known as. There are few genetic diseases like Colliers disease, Maffucci syndrome. These are all hereditary predisposition. When we talk about malignant bone tumors, see, there are three main malignant bone tumors like osteosarcoma, chondrosarcoma, and Ewing sarcoma. So they don't have any specific genetic, hereditary predisposition, but they have a genetic thing in that, like what we known as P53 tumor suppression gene, if you have heard of it. And one of the syndrome is Leaf-Romany syndrome, that had a patient, that is a pediatric patient, having retinoblastoma as well as an osteosarcoma of the bone. So these are few genetic predisposition is there, and as such there is no clear-cut causes. Like lung cancer patient will have a history of smoking, and that head and neck cancer patient will have a history of tobacco chewing, right? So these are the causal relationship is directly there. But in cases of bone cancers, most of the time it is what we known as somatic mutation. So somatic mutation is that patient has that in her or his body only, and it is not related to the germline, and that mutation will be shown in her or his body and leading to the cancer. So we have found out many of the mutations, but that detail will be out of the scope for this thing, I think.
Thank you so much, sir.
Right. Any other queries?
And sir, also in starting you mentioned that one female had a history of breast cancer and then
Right.
she was diagnosed with some bone tumor. So sir, is there relation between any relation between this adipose tissue cancer and bone cancer, or is it just a part of history taking of the patient?
No, actually, I think you missed the point that patient had a metastatic bone disease. So she was a known case of, she was a breast cancer survivor, as I already told, but the history taking was missed in terms of that she had a history of breast cancer. That breast cancer was metastatized to bone. That led to that lytic lesion in the bone. So it was not a second cancer. It was just breast cancer spreading to the bone. And that led to a misdiagnosis. So you're coming to a question that adipose tissue has any relation with the bone tumor. It is not directly related. See, these are sarcomas are what? Sarcomas are mesenchymal lining, mesenchymal tumors, what we say. So all the mesenchymal tumors like a bone and soft tissue, both are mesenchymal lining only. So they are related in that way. Like, so bony tumors and soft tissue tumors. Soft tissue tumors will consider that adipose tissues like a liposarcoma, then skeletal muscle tissue like a leiomyosarcoma, like vessels, that angiosarcoma. So these are all types of mesenchymal tumors. In that way, they are related, but not like some person having an adipose tissue tumor or a leiomyosarcoma or lipomyosarcoma will have a bony tumor. It is not related. Hope I cleared you.
Okay. Thank you, sir.
Welcome.
Sir, one query is nowadays palliative care comes into a picture in terms of management, pain management of various cancerous diseases.
Right.
So in bone tumor, what can be the role of palliative care in terms of pain management?
Okay. Palliative setting you are asking?
Yes, sir. Palliative care or pain management.
Like, see, palliative term comes when a patient has already a full-blown metastatic disease, right? Say, for an example, patient having a breast primary and then it has spread to multiple bony lesions or multiple visceral organs. So we are not going to cure that patient, first thing. And then the coined is palliative treatment, right? So what we have seen that it is known as skeletal related manifestations, skeletal related events, SREs they say. That is, they will have pain in the bone, they will have pathological fracture. The patient may require radiation therapy for the pain, and patient may require surgery because of the pathological fracture. So these are the four things that we see. And how we deal with it. Most of the time, if the patient is having bone-only mets, and say, for example, it is in spine or something like in scapula, a non-weight-bearing region to be safe. So we'll give a palliative radiation to that patient. Palliative radiation is like routinely we'll do a single or two shot radiation to that local site, and they will have an excellent pain relief. When we come to the pathological fracture, like in a proximal femur, something like that in a weight-bearing zone, we'll advise a pathological fracture fixation at the most, and after that, palliative radiation for the same, so that the patient has mobility, whatever the time he or she has left for the after this thing. So palliative means that quality of life. We try to improve the quality of life of the patient. And few of the cancer histology also had a say on it. Like a breast cancer that is hormone responsive, usually they have a good life prognosis. So they have good quality of, they need to be given the good quality of life. So I have also quite a good number of patients who had a proximal femur lesion, and I have replaced them with a tumor megaprosthesis, so that the lesion tumor is altogether gone from that side, and patient is immediately mobile after a say after suture removal 10-15 days. So that has to be dealt patient to patient on a subjective basis. And in cases of extreme, I mean, we are not going to help in the terms of surgery, then we'll be using analgesic in terms of morphine and
Okay, thank you, sir. So one more query is that what can be the role of a physical therapist for the rehabilitation post-operative in this particular type of tumor?
Actually, they have a great role, actually, because see, just to give an example, like we are discussing a tumor of distal femur, right, or a proximal tibia, this proximal tibia tumor, that is a malignant one. And say, for example, I have resected 12 centimeter of a proximal tibia, and because the joint has been resected, and the patellar tendon that sits on the tibial tuberosity, we usually lift it off, and our megaprosthesis had a slot for the reattachment to that bone, this thing, megaprosthesis and the patellar tendon. So after that, the reconstruction has been done, but patient has to be kept immobilized for 6 weeks, so that the patellar tendon and prosthesis and the muscles overlying it, they got fibrous enough for that extension mechanism works. And I have come across many of my patients, because like I have few of my patients from Vapi, Valsad, Navsari as well. So many of time I do operate them at Surat, but they will be transferring back to their native places only. So I have to explain to the physiotherapist that, like this, like I will give the example the same only, that most of the time they will be doing an open chain exercise for the this extension mechanism. So I advise them that go for closed chain exercises, so that the extension leg improves a lot. So this is just an example that proximal tibia megaprosthesis and role of physical therapist, as well as we have quite a few tumor that extends the whole femur. So sometimes we replace the whole femur, total femur, I mean, both the hip joint as well as the knee joint. In these cases also, we need to have a good physical therapist who can make the patient walk without, obviously they will have some sort of limp, but still patient can be mobilized without any help or like that. So definitely you people have a very great role in terms of rehabilitation. We have a great paper, I think I don't remember the paper only, but they have a great paper for tumor reconstruction and followed rehabilitation.
One question is coming from Mr. Daljit Diman. So if a person above the age of 65 and has low bone mineral density, then what will be the management of bone tumor? You can read the question in the chat section, sir.
Where is that? In the message section?
In the chat section, sir.
Right.
There is one icon of message.
Yeah.
Okay, let me. Can you see that?
Okay. Yeah, I have read it. If the person is above age 65 and low BMD, so patient is basically an osteoporotic patient, right? And the management of the bone tumor will remain the same, like whatever. I mean, if he has not mentioned whether it is a primary bone tumor or a metastatic bone tumor, first of all, because more than age of 40 will think of a metastatic bone disease first. So that treatment will remain same, first of all, and we'll try to improve the osteoporosis of the patient, like the injection zoledronic acid or injection denosumab, that also helps in bone quality improvement as well. So the treatment of the tumor part will remain the same, but the medical management of the osteoporosis will come into play.
Okay, sir, one more query is, can exercise increase the level of metastasis, or it can spread the cancerous tumor? Like many times, if we make patient to do exercises, so can exercise worsen the situation?
I'm not getting the whole situation. The patient is a known case of bone tumor, or?
Yes, sir. Bone tumor is there. Okay, operated. Right now, the patient is in the rehabilitation phase. Okay, and exercise is being performed by the patient. So, are there any chance of?
No.
Okay, sir.
No. There is no chance that once the tumor is removed and blocked, we are talking about a malignant tumor only. That if the tumor is removed and blocked with a wide margin, and after that obviously we'll advise physical therapists to do this thing, and they will do under their supervision. So there is no chance that after the removal of the tumor there is a spread of the disease. Even in cases of giant cell tumor, like in cases we do extended curettage and we don't remove the tumor end block, we just do a marginal excision. Even in that cases also, we require a good physical therapist, and it doesn't spread the tumor proximally, or if that is a thing that is you are concerned about.
Okay, thanks a lot, sir. So we are done with all the queries regarding the bone tumor and the management of it. Thank you, sir, for your valuable time and valuable knowledge that you shared with the participants. Okay, we do have participants from across the country as well.
Okay, that is great.
Many of the participants were unable to join because the Google Meet has the limit of 100 participants. Otherwise, it could have been 150 or 200 participants. So once again, on behalf of Srimad Rajchandra College of Physiotherapy, I thank you, Dr. Rahul Parmar, sir, for sharing his knowledge. I also thank you, Dr. Niyati Desai, today's moderator, okay, for the concluding remarks and for the introduction of the speaker, and also to all the participants, okay, for being here in this webinar, even on Sunday. So thank you all. And here I am sharing a Google form link in which you can fill up the details, and the certificate will be provided to you in a day or two on the given email ID. So here I'm sharing the Google form link in the chat section.
Thank you. I take
Thanks
your
a lot,
leave.
sir.
Yeah. Welcome. Bye.
Thank you a lot, sir. Have a nice day. Thank you all. So here we are end up with today's webinar, that is the diagnostic approach to bone tumors and the management of benign tumors. Thank you once again. Have a nice day.